Hello, my name is Metoděj Renza, and I am a colleague of Roman Sýkora. He prepared this lecture for you. It's about the airways and mechanical lung ventilation. Today we will talk about the airways, oxygenotherapy, and capnography.
In the beginning, we'll talk a bit about the airways and anatomy of the airways. The first part is nasal cavity and oral cavity. In the mouth, we have a tongue and the root of the tongue. Then we can go through the nasopharynx to the oropharynx, and the mouth and the nasal cavity is divided by hard palate and soft palate. Under the oropharynx, we have hypopharynx, and there are two entrances. One is to the esophagus, and second one to the larynx. Entrance to the larynx is covered by epiglottis. In the larynx, we have vocal cords. Under the vocal cords, we call it lower airways. If we are talking about the critically ill patients, point number one in the chain of survival is A, airways. This is the most important thing in the chain of survival, and we go step by step. This is the step number one.
Within the ABCDE algorithm in the care of critically ill patient, A is from the English, airway. Mostly we talk about airway patency. Each letter of this algorithm is not only an examination, but a sequence of actions that begin with an examination and lead to interventions that further have a goal, ideally physiological state. In the case of point A, there are clear airways. As a part of the approach to critically ill patients, we assess ABC points almost simultaneously. For educational purposes, we will go only through points A and B in this lecture. It should be noted that ABCDE is evaluated and whenever a patient changes their conditions or in the event of a sudden change, for example, ventilation circuit breakdown. But let's go back to the beginning. Airway patency is the first approach to the patient. Mainly the upper airways patency is examined. We can hear various sound phenomena, gasping, snoring, bubbling, or extreme head positions that can cause airway obstruction. We may have a problem with a foreign body in the nose, mouth, nasopharynx, or lower airways. Most often, however, is the fluids, vomit and the blood that obstruct the airways and can flow deeper into the airways, and these fluids can obstruction or aspiration pneumonia. The solution is to clean the oral cavity and the rest of the airways. Usually this operation is done with a suction machine. Very important airway obstruction is swelling. Swelling of the tongue in case of allergic reactions, and general swelling during anaphylaxis or inhalation trauma. Also secondary airway swelling causing obstruction. The most common and the most obstructive airway obstruction is due to the fact that the root of the tongue and soft tissues work on the hypopharynx by gravitational force and may have fatal consequences in an unconscious patient. This brings us to the interventions in point A. By clearing the airways, we achieve just by tilting the head, lifting the chin, and in a patient suspected of having cervical spine injury, simply by moving lower jaw forward. Airway cleaning and suction is also very important intervention for airway patency. In some cases, it is necessary to use one of these airway aids. For simple airway tube, laryngeal mask, or in a case of swelling and imminent further deterioration, definitive solution is endotracheal intubation. Coniopunction, tracheotomy, or tracheostomy can also be performed, but only in emergencies without a possibility of less invasive choice in imminent danger of the patient's life. In the case of a patient with impaired consciousness, in the trauma with signs of shock during CPR, or in a patient with dyspnea and impaired oxygenation, oxygenotherapy is already showed at this point and is therefore included in this algorithm. In the picture in left top corner, you can see the anatomy model of airways. In the right bottom corner, you can see the picture when the patient is unconscious and the soft tissues are falling in and laying in hypopharynx, and our airways are obstructed. In the picture, you can see unconscious patients. We have to chin lift until head. We listen, we look at the patient's chest, and we feel if patient is breathing or not. If we are checking these vital conditions, breathing and palpation of pulse on the carotid artery, we should do it less than 10 seconds, following by guidelines of European Resuscitation Council. The first hand we place on the forehead of our patients and we push to the back. By the second hand, we lift the chin and then we are checking his or her breathing. You can imagine this technique like you can see in the picture. Tongue is lifted up from the hypopharynx and our airways are open. Sometimes we have contraindications for tailhead, for example, it's injury of C-spine or cranial trauma. If we have contraindications for tailhead, we only chin lift as you can see in this picture. We are holding angle of the mandibula and lifting up the chin. Basically, by this maneuver, we are lifting up the root of the tongue up from the hypopharynx and our airways are free. Still, it's in conditions where we don't move by the spine. There you can see another technique in two rescuers. This technique is usually used for trauma patients. The first rescuer is holding the angle of mandibula and the second one is lifting up the chin. This could be very effective at trauma patients where we don't want to move the C-spine. In this picture you can see inline stabilization of whole spine. You can see the neck collar and also special board for fixation of the rest of the spine. In this picture you can see the final motion restriction which we use for trauma patients, and these patients absolutely cannot move at all. There are many differences in anatomical conditions between children and adults. Usually it's larger tongue, higher glottis, and cricoid area is narrow. There are another anatomical examples. Children have bigger occipital bone and adults they have more soft tissues on the neck and between scapulas. These anatomical circumstances are reason to place our small patients to this sniffing position and do not tilt the head. Now we are in the end of the point number 1. A. Airways. Our patient has free and open airways and can breathe spontaneously. but we don't know about oxygenation and ventilation. So this is point number 2b, breathing. If a patient has their own respiratory activity through airways and effective ventilation, they may still need oxygen treatment called oxygenotherapy. It's an increasing of inspiratory fraction of oxygen. The aim of oxygenotherapy is to eliminate arterial hypoxemia. Thus, if alveolar hypoventilation is present, oxygenotherapy will be poorly effective if there is a causal right-left shunt. Indications for oxygenotherapy are various states of hypoxemia, often associated with dyspnea, shock of any etiology, cardiac arrest, then in the intoxication with cyanide and carbon monoxide, acute myocardial infarction, and in various situations in trauma patients. Oxygen delivery techniques are different in their ability to maintain a constant inspiratory fraction of oxygen. This fraction depends on the oxygen flow and the way of administration. An example of flow oxygen system which supply high inspiration fraction of oxygens are Venturi's face masks. There are possibility to set inspiratory fraction of oxygen between 25 to 45%. In daily practice, we will meet more with low-flow systems. These systems are not able to set in a variable inspiration fraction. This inspiration fraction depends on a flow of oxygen, dead space, and tidal volume. One of the basic representative of these systems is oxygen nasal cannula, which can supply inspiration fraction maximally to 40%. These nasal cannulas are failing at the patients which are breathing by mouth. Open face mask in right top corner can supply inspiration fraction between 35 to 65% if the flow of oxygen is from 6 to 12 liters. Face mask with reservoir can supply inspiration fractions from 60 to 80%. During experium is reservoir filled by exhaled gases. If we use mask with one-wave valve system, we can increase inspiration fraction over 80%. Oxygen saturation of peripheral blood is measured by pulse oximetry. Normal value could be considered more than 92%. Normal target of the value we would like to achieve in oxygen therapy is exactly this number. The hemoglobin dissociation curve shows dependence of hemoglobin and saturation on arterial oxygen tension. It is this dissociation curve, but what is important is to realize that the decrease in hemoglobin saturation is or reflects a decrease in arterial oxygen tension only to some extent. For example, as saturation dropped to 70%. Consequently, the decrease in arterial oxygen pressure is more dramatic, and the values measured by the saturation sensor are difficult to rely on. However, it's necessary to know how to administer oxygen. Oxygen is a drug and needs to be dosed somehow to our patients. To significantly simplify the situation and within the urgent conditions and critical states of our patients, and if we use an open mask as our oxygen delivery system, remember that we will deliver 15 liters per minute and further adjust the oxygen flow or reduce it according to the achieved saturation, with our target being 92%. In case of long-term oxygen administration, it's necessary to humidify in it in some way. Here is one example of how it can be done. I have a little quiz at the end of the oxygen therapy subchapter, and that's how long do you think we can use a full 2 liter bottle of oxygen, for example, in CPR or an unconscious patient within polytrauma, while the oxygen is running at 15 liters per minute, which is the recommended dose. This bottle lasts 16 minutes. We can save something by reducing the oxygen flow according to saturation. In case of 4 liters per minute, I can use this bottle for 1 hour and 15 minutes. In unconscious patients, it's difficult to keep open airways, and therefore we can use the oropharyngeal airway. The oropharyngeal airway is a device that is placed into the oral cavity along the tongue root into the hypopharynx. To determine the correct size of the oropharyngeal airways, place its upper part at the corner of the mouth and the lower part reaches the angle of the mandible. You can see measuring in the picture. If we have measured the correct size of the oropharyngeal airway, we place airway to patient's open mouth. So the convexity of the airway is caudal. This is how we put it in her mouth. Gradually, we rotate the oropharyngeal airway in the mouth by 180 degrees, so that concavity gradually follows the course of the tongue and points the lower end of the airway into the hypopharynx. This is the target state that we want to achieve after the placing of the airway. The oropharyngeal airway is indicated only in deep unconscious patients who do not respond to the insertion of the airway. Patients have no reflexes, such as a emetic reflex. In these patients, we can introduce airway into the mouth and vice versa can help us, for example, to ventilate patients through the face mask. In cases where ventilations while holding the mask by EC clamp is not very successful. Another possible aid for patients with impaired consciousness and worsened or obstructed airways is the nasal airway. We can place airway through patient's nasal cavity and direct it deeper to hypopharynx and keep the airways passable. The correct width of the nasal airway should be approximately the width of the finger of the patient. The length of the nasal airway should be from the nostrils to earlobe. If we have selected the correct width and length of the nasal airway, it must be inserted. First, it's necessary to lubricate the nasal airway with a water-based lubricant and then proceed insertion. We enter by the right nostril so that it points upwards. Only after it enters the nostrils, so we begin to rotate the nasal duct 180 degrees. Slowly try to insert them vertically along the hard palate so that we direct airway into the hypopharynx. After the nasal airway has been inserted, the patient may still not have full patency of the airways, and it will be necessary to maintain either chin lift or lower jaw protrusion. On the other hand, a properly installed nasal airway, either oral airway, can significantly help us in ventilation the patient through the face mask. In some cases, the placing of nasal or oral airway is not sufficient and the patient does not show respiratory activity or inadequately breathe. We need to ventilate the patients by the ambu. For this purpose, face mask should be worn and properly worn. There are two grips that will be gradually shown in these, and these grips allow us to hold the mask properly. This is a CE grip when one hand tilts the head, lift chin, and trying to move the lower jaw upwards. The forefinger and the thumb are holding the mask pressed over the patient's face, mouth, and nose. This is a relatively difficult grip that can be handled by more experienced anesthesiologists or needs relatively enough training. CE grip in inexperienced hands may not be effective. There may be a number of leaks, the improper holding of the mask, or insufficient force to allow the face mask to press sufficiently and hold it properly on patient's face. Therefore, a method has been developed where the mask is held by one rescuer. If you want a doctor holding the mask by both hands, he holds the mask and tilting patient's head and lifting patient's chin up. The important thing that the both thumbs are placed on the mask that is held tightly on the patient's face, and during ventilation, doctor tries to check for any leaks. The disadvantage of this method of holding face mask and ventilation this way is that the patient must be ventilated by second rescuer. This is a modification where an incomplete double-sided CE grip is used. What is the most important? It's to follow the principles. This means having a slight head tilt and sealing mask to best, so that the patient ventilation is effective. We are checking that each artificial breath is followed by chest lift. When we are ventilating the patient by a self-expanding bag or ambu if you want, without oxygen connections, we have a 21 inspired oxygen fraction. If we connect the ambu at the moment without the reservoir, the oxygen at the flow rate of 15 liters per minute, we are able to reach an oxygen inspired fraction about 45%. In case the oxygen reservoir is connected to self-expanding bag and the condition of connection to high-flow oxygen is maintained, we achieve inspired oxygen fractions up to 85% and almost 100% inspired oxygen concentration if you use two one-way valves. The respiratory tract should be kept in some unconscious patients. For example, in pre-hospital care, it may be patients with severe consciousness disorder and oxygenation problem, patients during cardiopulmonary resuscitation, or in the case of planned procedures under general anesthesia, or as a rescue procedure. The introduction of the laryngeal mask is less invasive than endotracheal intubation. Laryngeal mask is a device used to keep the open airways. The laryngeal mask is inserted through the mouth and allows to ventilate the patient. This picture shows several types of laryngeal masks. The largest is the classic laryngeal mask with inflatable cuff that seals the correct position of the laryngeal mask in the hypopharynx. At the very top, the green one is an eye-gel mask that does not inflate in any way, and when the mask is properly positioned, it adapts to the patient's anatomical conditions and is very easy to place. Laryngeal mask is placed by this simple maneuver without any additional aid. The head is slightly tilted and the mouth is open. We try to slide the mask down to the root of the tongue. After we reach the root of the tongue, we feel a slight relaxation and the mask settles directly into the position what we need. What can be imagined this way? Here is a correctly placed laryngeal mask. It can be seen the distal part is directed to esophagus, which closes. Main part distally urges to enter the airways, so that the placed laryngeal mask allows the trouble-free patient ventilation. However, the laryngeal mask is not considered as a tool to 100% prevent microaspirations, which are limit its use, for example, in emergencies, use in pre-hospital emergency care, or for a certain spectrum of anesthesia procedures. Another way of keeping the airways open is to perform endotracheal intubation. Endotracheal intubation requires that the patient is unconscious, has no reflexes, We need an unconscious patient, possibly prepared in some way pharmacologically. That is to say, under general anesthesia and paralyzed. For endotracheal intubation, we need a laryngoscope, which is this curved blade device with handle. This is a Macintosh type of laryngoscope. On that curved blade you can see the light that shows us the anatomical structures. It is a direct laryngoscopy, and an anesthesiologist places an endotracheal tube under visual control. The laryngoscope is inserted into the mouth. The patient's head is tilted, starting from the right side, holding the laryngoscope by my left hand and gradually pushing the patient's tongue to the left side, and then view the entrance between the vocal cords to larynx. Here is a look at the vocal cords through which the endotracheal tube need to be moved deeper into the trachea. Under our visual control, we should also see the balloon, which is located at the tip of the endotracheal tube. An endotracheal tube is positioned in this position. Distal tip of the endotracheal tube is located sufficiently high above the carina. This means that it is not placed most often into the right bronchus, and position allows ventilation of both lungs. The balloon is completely placed under the vocal cords. At this point, we can inflate the balloon so that completely sealed airway. Ventilation takes place through the lumen of endotracheal tube. Inflating the balloon has two basic functions. One is to stabilize the position of the tube, and the other to prevent microaspirations. For the sake of completeness, it's necessary to mention that the endotracheal intubation is needed that the patient was fully unconscious and or his consciousness and muscle activity was fully discontinued. Then endotracheal tubes can be used in analogous sedation, for example, combination of an opiate such as sufentanil with benzodiazepine or propofol. It is necessary to use some muscle paralyzation. The paralyzing myorelaxants example is atracurium for prevention of an interference between patient and ventilator. After intubation of the patient, it's very suitable to verify the position of endotracheal tube not only by listening on the both sides of the chest but also by capnography. After intubation, a capnographic curve of approximately this shape should appear on the monitor. This is a gold standard for confirming that we are truly by endotracheal tube in trachea and we are ventilating the patient. Normal exhaled CO2 values are from 35 to 45 millimeters of mercury. In case you meet monitors where this number is expressed in kilopascals, can be divided by 7.5. CO2 monitoring has a different designs options and different sensors. In this case, the tube with the tubing is connected to the ventilator circuit and the orange part is connected to the patient monitor. It should be noted that in this case it's not necessary to connect the orange connector to device first and then to the patient circuit. Then we will see the capnographic curve, that is the orange one, and the value of 38 millimeters of mercury, that is also orange. There are also ventilators with end-tidal CO2 sensor and analysis. Then they are supplied with disposable circuits directly with the tubes that are part of the disposable circuits and lead to the sensor, which is located exactly in the ventilator. The ventilator display then shows a capnographic curve. Capnography can also be displayed in patients who are ventilated by the face mask. For example, when the capnographic tubing is pulled from an anesthesiologic device, where a sensor is placed in a filter where sample of air is taken for analysis. This is how we analyze exhaled CO2, for example in patient during CPR, until we have a final airway management, for example by endotracheal tube. Capnography can also be monitored in spontaneously ventilated patients, where the sensors are placed in the nose, but on the other hand, I think this goes beyond the scope of this lecture. In this figure, the capnographic curve as it actually appears is shown in more detail. It's the orange curve of the lowest of all. The capnographic curve begins with zero and begins with exhalation, and the exhaled CO2 pressure value gradually increases. Then the growth stops and there is an alveolar plateau, followed by inspiration, and the curve returns gradually to zero. This is periodically repeated depending on how the patient is ventilated or how the ventilator is set up, or how the patient spontaneously ventilates. If capnometry values increase, this means at a higher exhaled carbon dioxide pressure, we may conclude that the patient is probably hypoventilated. In the case of a decrease in capnometry, this means in the case of a decreased amplitude, we may assume, for example, that the patient breathes at high frequency. This patient is hyperventilated. For us, this data is very important because we set the minute ventilation or tidal volume level according to these parameters to achieve normocapnia. This means an end-tidal CO2 between 35 and 45 of mercury. Capnometric curve and capnometry can tell us a lot about the patient's minute ventilation. If capnometry increases and reaches a value greater than 45 mm of mercury, it can be assumed that the patient is hypoventilated. In this case, minute ventilation should be increased. This can be done by increasing the tidal volume, and if we have reached a sufficient tidal volume, then we can increase frequency. On the other hand, if capnometry decreases, which means end-tidal CO2 values falls below 35 of mercury, it can be concluded that the patient is hyperventilated. Again, we can manipulate minute ventilation. In this case, we can reduce it. Capnographic curve and capnometry is not just a picture of ventilation. Cardiac output is also involved in the capnographic curve, respectively, in the value of capnometry. This is due to the close connection of heart and respiratory system. Patients with low cardiac output also have a low capnometry values. An example of low cardiac output or no cardiac output is sudden cardiac arrest. If the chest compressions are good, and the patient is monitored at end-tidal CO2, we can see values around 22 mm of mercury. This value is only achieved with high-quality chest compressions. In such cases, the sudden increase in end-tidal CO2 in a patient being ventilated during CPR may be indicative of a return of spontaneous circulation and entitles us to check the rhythm of heart on the monitor. This check can be performed out of the usual 2-minute period, which is intended for rhythm control. Not only the value of capnometry, but also the shape of capnographic curve can be guide for us like a clinical guide. In patients with lower airway obstruction, such as COPD patients, they have prolonged expiration together with higher capnometry value. The shape of the curve is roughly the same as in the figure. We can conclude that the lung obstruction is present. Capnographic curve also helps during general anesthesia. The fading of the neuromuscular block is shown on very top curve. The next curve depicts a band or obstructed lumen of endotracheal tube or foreign body. Eventually, this may be the case of obstruction of the exhalation part of the circuit or of incipient bronchospasm. The lowest place curve shows the shape that appears when the cuff of the endotracheal tube is insufficiently tight. In the end of this subchapter, we present several capnographic curves and their shape in various clinical situations. We have come to the end of this slideshow, and it's necessary to summarize one of the most important points. The ABCD critical patient care algorithm is prioritized. In this case, A and B are the most important. Airway patency, then adequate patient ventilation is also very important. Without the points A and B, the other points are useless. In the presentation, we haven't said it, but if the ABC patient finds that he's not breathing, not responding, and you don't feel the pulsation, you need to call for help, say loudly resuscitation, and start compressions. Oxygenotherapy at critical patient, we begin at 15 liters per minute and gradually reduce the oxygen flow according to achieved saturation. Our goal in saturation is 92%. On the dissociation curve of hemoglobin, we have shown that the saturation reflects some extent arterial oxygen pressure, but only to some extent. Saturation below 70% lacks meaning, and all patients who have achieved such a low saturation must be treated as being the most critical condition and initiate care according to ABCD algorithm. Laryngeal mask can be very important life-saving aid even in hands of a less experienced rescuer. But be careful, endotracheal intubation is the gold standard and especially for long-term airway management. The most important of this lecture is to take the importance of monitoring entitled CO2, capnography and capnometry, and how we can use these data. Thank you very much for your attention, and I'm looking forward to seeing you at the next lecture about mechanical lung ventilation. Goodbye.